Hey, welcome back. You guys have just completed week 5. You're getting your way through uh, anatomy, and we're going to be going into physiology here pretty soon. And this week we're going to talk about drug exam number 5. Now, drug exam number 5 is going to cover a couple IV solutions and some medications that we call vasopressors. Vasopressors are medications that we give via IV infusion to get the patient's cardiac output up, get their blood pressure up. So, the first one we're going to talk about is normal saline. Normal saline is an IV solution, and when you think of getting an IV, most people think of normal saline. Now, normal saline is a isotonic IV solution. What do I mean by that? What I mean by that, when I say isotonic, that means that it neither draws water into the cell nor pulls water away from the cell. So it keeps the cellular hydration the same. So we use normal saline as a fluid replacement. It is for someone who's had diarrhea for a few days and they've gotten dehydrated, or they have some other ailment, sepsis, that has got them dehydrated, and we need to replace fluids. Now, there's some risk associated with that as well. If they're already fluid overloaded, if they have trouble getting rid of fluid, that's going to be a complication with giving normal saline. So we don't want to overload the circulatory system for patients in heart and renal failure. Now we'll talk about that in much greater detail, but I just want you to remember that key point that we don't give patients that are in heart failure and renal failure a tremendous amount of normal saline. We don't want to overload them with fluids because that fluid's got to go somewhere and it ends up in the lungs, and that's not a good thing to happen. So that's the one real problem with if we gave too much normal saline. Now, when I say that it is a fluid replacement, we give it a lot for patients who have had some type of injury with associated bleeding. It's not the best fluid replacement for people who have had hemorrhage or other types of blood loss. The reason is that we're just putting salt and water into the system. There's nothing in normal saline that carries oxygen. There's nothing in normal saline that carries carbon dioxide. It is literally just fluid replacement. So your blood has clotting factors in it. And if you start putting a bunch of saline into your blood and you dilute it like you make weak Kool-Aid out of your blood, what happens is your body doesn't have as much overall clotting factors for that fluid, so it's harder for you to stop bleeding once you've gotten a bunch of fluid. So in that situation where we've had hemorrhage, the ideal fluid replacement is blood and blood products. So we do use normal saline, but sometimes we have to think about what we're trying to do and what fluid are we trying to replace because of those types of issues where it's not the ideal fluid replacement. The next medication we're going to talk about is dobutamine. There is a group of medications that we call vasopressors. And what vasopressors do is they increase cardiac output. Increased cardiac output is a fancy way of saying they increase the blood pressure. And they do that in different ways. And that's why we carry different types of pressors, because we use those in different situations where one type of pressor might be better than another type of pressor in a specific situation. So let's talk about dobutamine and when it is best. Okay, dobutamine is a vasopressor, like I said. it has a positive conotropic and a positive inotropic effect. Those are big words. Don't let them intimidate you. What positive inotrope means is that it increases the contractility of the heart. It makes your heart beat harder and squeeze more. And what it conotrope means is that it makes your heart beat faster. Now, I told you just a minute ago that dobutamine is it's in that bucket of vasopressors, but it actually has very little vasopressive effect. It doesn't affect the container as much. So dobutamine works by turning up the pump, and it affects the beta 1 receptors, and it is really best in patients with heart failure and cardiogenic shock. And the dose for that is 2 to 20 micrograms per kilogram per minute. Now, this is the first time you've heard talking about an amount of drug times their weight times per minute. So that's the med math that you hear about from your partners, like, oh my gosh, I struggle so much with med math. And that is one of those situations. But we're going to teach you how to deal with that, and we're going to practice and practice and practice. So at 2 in the morning, when you've gotten dragged out of bed and you can't hardly get the crud out of your eyes, you'll be able to calculate those drip dosages that we're talking about. Yeah, so we're going to go ahead and move on to our next pressor, and that is dopamine. Dopamine is a pressor, a vasopressor, but it works in a different way. It has a positive inotropic effect, but it also has a powerful, I shouldn't say powerful, but a strong vasoconstriction effect. What I mean by that, it makes the blood vessels smaller. It makes the container smaller. Now, when you have a set amount of fluid, your blood, and it's in a container, your blood vessels, if you make that container smaller, Boyle's law tells us that the pressure must go up. So that's how we do it. We take and we give dopamine, and it reacts to the beta 1 receptors in the vessels, and it makes the vessels constrict, makes them get smaller. And what happens there is that will hopefully increase the blood pressure. Now, the dose of dobutamine is 5 to 20 micrograms per kilogram per minute. All right, and that can be given IVIO. Now, this will always be in a drip. The drip is pre-mixed. It's 1,600 micrograms per kilogram, or excuse me, 1,600 micrograms per milliliter in that situation. And so you notice that there's a wide range of medication there, from 5 to 20 mics per kilogram per minute. That allows you to titrate it to figure out how much vasoconstriction we need to get the blood pressure up, because we don't want to cause so much vasoconstriction that we cut off circulation to the extremities and to the skin. And so we titrate that to get our blood pressure, and I really shouldn't even say blood pressure, I should say to get our MAP above 65. All right, so let's talk, and yeah, I already talked about the dose, so let's go on to the next one. And we're going to talk about norepinephrine, or better known as Levophed. Okay, now norepinephrine, if you remember, is a hormone within the body that is naturally made, and it is a powerful vasoconstrictor, a powerful vasopressor, and it works by activating those receptors in the vessels and making them really squeezed down. Now, it is much, much of a stronger vasopressor than what dopamine is. And if you give too much Levophed for too long, you can actually vasopress someone down to the point where their skin does not get perfused, their extremities do not get perfused. And there are horror stories out on the internet where people that were given high doses of Levophed for a long period of time to save their life, they've actually lost hands and legs and feet from that long use of Levophed, because of that vasoconstriction that just keeps getting smaller and smaller and smaller. And at some point, it gets so small that perfusion out to those extremities is completely lost. And basically, those extremities die. There's just no other way of putting it. So the dose for Levophed is 0.1 to 1.5 micrograms per kilogram per minute. Again, a wide range of dosage, and that allows you to titrate it to your patient's specific needs, because you don't want to get them vasoconstricted down so much that they lose peripheral circulation. We got to find that balance. And I think that's all I wanted to say about that. And it is best used, it's the best first-line vasopressor for neurogenic shock. The next medication we're going to talk about is not a vasopressor. It is called tranexamic acid, or TXA. And what TXA is, it is a medication that we give via IV infusion, and it prevents the body from starting to break down clots that have already formed. We know when we have an injury and our body is insulted, the body has all these types of mechanisms to start the healing process of that insult. And one of the first things it does is that the platelets form and they aggregate. And what I mean by aggregate, the platelets come together and they start to stick together. Okay, and that's called aggregation. Now, they're not strong enough by themselves. So what comes in next is a material called fibrin. And fibrin is like strings that tie the platelets together, and fibrin kind of keeps the platelets from breaking apart and makes that clot stronger. But here's the thing, that a vast majority of the problems that the human body has is due to clogged pipes. A heart attack is a clogged pipe. Ischemic stroke is a clogged pipe. All kinds of problems. That PE is a clogged pipe. Kidney stone, clogged pipe. All those things, those clogged pipes are bad. So the body does not like clogged pipes. So after a short amount of time, that fibrin has collected on those platelets to form that clot. The body starts to work to break down that fibrin so we can start the healing process. The problem is, if the patient's bleeding and they need that clot to stay there, the body starts getting rid of it. And we don't want that to happen. So we can give TXA in that situation. And what TXA does, it inhibits the activation of plasminogen and therefore reduces that fibrin clot reinforcement from breaking down. So it gives the body more time to control the bleeding before the healing process starts. So it will help reduce internal bleeding. It can also be given for postpartum hemorrhage, and it can be given for blunt trauma injury as well. Now, we don't have the protocols for it, but I've even heard of agencies like in England squirting TXA into a wound to cause that bleeding to stop. And it's pretty fascinating, really. But how we give TXA here is IV infusion. And typically the dose for TXA is 1 gram IV infusion given over 10 minutes. So you take 1 gram of TXA, you squirt it into a 100 milliliter bag of IV solution, and then you infuse that over 10 minutes. And what that allows you to do is get TXA on board quickly. Now there's one important caveat with TXA. It cannot be given if the injury happened greater than 3 hours ago. And I'm not talking 3 hours ago-ish. I'm talking about 3 hours. If it's 3 hours and 5 minutes, we do not give it. If it's an hour or so, hopefully it's that time frame, we will go ahead and give TXA for a patient who has hemorrhage that we can't control via tourniquets, direct pressure, all those other things, or internal bleeding as well. But if we're at that 3 hour point, we do not give TXA. All right, let's move on to the next one. The last thing we're going to talk about is another IV solution, and it's called lactated ringers. Sometimes you'll hear it referred to as Hartmann's solution, but usually it's called lactated ringers or LR. What is LR? LR is another form of IV solution. Again, it is an isotonic crystalloid solution. It does not promote fluid going into the cell or out of the cell. It is isotonic. It can be given for fluid replacement as well. The dose for it is 20 milliliters per kilogram given IVIO over 15 minutes. Very similar to what normal saline is. The difference between normal saline and lactated ringers is that lactated ringers contains potassium and other electrolytes. Normal saline only contains sodium and water, nothing else. Lactated ringers, it also has potassium in it and other electrolytes. So that makes it a little bit more complicated than normal saline. Some agencies don't even carry LR on their trucks. Some agencies carry both. I think most agencies at least carry normal saline. I don't know of any agencies that only carry LR. But again, one thing we have to watch for is the potential for fluid overload. So we want to make sure that before we give the patient a bunch of fluid, we make sure that we have good lung sounds. There's no fluid in the lungs because we don't want to overload the circulatory system. Now, we're 5 weeks into the paramedic class, and I know that these pressors are a lot. I want you to understand that we recognize that. We don't expect you to be able to be proficient in administration of these medications right now. We are just learning how they work. We are going to implement these medications into class a lot through ACLS, through PALS, all those things, even in trauma. So I don't want you to feel overwhelmed with these pressors, these vasopressors, because they can be a lot. What I want you to remember is their trade names, their generic names, the dosages, and the important things like which one to give where, and we will build on this fundamental knowledge as we go through. Well, that's all I have for this week. If you have any questions, please, please, please ask your instructor in class, and we will help you navigate through this. This is high level stuff. So if you feel completely overwhelmed with these, that's completely normal. I'll be honest, I had to refresh myself on these every time I talk about them because it's a lot. It's a lot. All right, that's all I have. We will talk to you soon.